right, sensory receptors of the vasculature. So the big one that I definitely want to hit on here is going to be the baroreceptors. So the baroreceptors are going to be located at the carotid sinus and the aortic arch. Okay, so what baroreceptors essentially do is they're detecting changes in the blood pressure. Just like the endothelial cells, we already talked about their regulation, their automated regulation of increasing nitric oxide in response to changes in shearing stress or acetylcholine or bradykinin, right? The baroreceptors will also detect changes in stress, particularly at these two locations. Now, the way that you can get stumped on a baroreceptor question is if they start going into the details, okay? So the details, of course, is what step one is really founded on, are these mechanisms. If I have my carotid sinus, okay, so this is, again, here's my carotid artery, and again, this is going to be located at the dilation of actually the internal carotid artery located just above the bifurcation of the common carotid artery. And I don't want to kind of go into the anatomy because it's not as important, but the point is, let's just say that here's my carotid sinus. Okay, so here's my carotid sinus, and the carotid sinus is going to respond to changes in pressure. So again, if I increase the pressure, what we're saying here is if I increase my blood pressure, then there's going to be more firing here. Okay, so think of it like it's firing the signal saying, hey, there's an increase in the blood pressure. Okay, so as there's more pressure, there's more firing. Okay, so this firing is then going to send a signal up over to the medulla. It sends this signal using cranial nerve 9, okay, the glossopharyngeal nerve. So it's going to send that signal to the medulla. What part of the medulla? It sends it to the nucleus solitarius, okay? So it sends that signal to the medulla. Again, the big thing is that this is in the medulla. And then this is going to be your afferent signal. So you would have increased firing from the glossopharyngeal nerve. And then from the medulla, there's two signals that can be sent out. One is going to be parasympathetics. Okay, so the parasympathetics, I'm going to put PNS for parasympathetic nervous system. So the parasympathetics are primarily going to send the signal to the SA node and potentially the AV node. And it's going to do this through which nerve? It's going to be the vagus nerve, right? Cranial nerve 10. It's going to send it to the SA node. It's going to say, hey, the blood pressure is a little high. Let's slow things down. Let's keep our cardiac output, at some, steady state. And so that's the idea. That's where the peripheral nervous system is going to come in. Now, the sympathetic nervous system is also going to have regulation here. So the sympathetic nervous system is also going to send a signal from the medulla, only it's going to go down through the sympathetic chain. Okay, so let's just put sympathetic chain. Okay, and this is going to be the sympathetic nervous system. And then it's going to send its signal down. Again, it could send its signal to the SA node, okay, or the AV node, but it can also send its signal to blood vessels, okay, to vascular blood vessels. And again, we already kind of know how the sympathetic nervous system does this. Potentially, if I wanted to induce vasoconstriction, I can hit up the GQ pathway, for example. I can have alpha-1 binding to GQ. That can cause vasoconstriction, right? Because that will cause increases in diacylglycerol, protein kinase C, getting more calcium coming into the cell. And also I can generate IP3. I can knock on the door of the sarcoplasmic reticulum and get more calcium-induced calcium release. So those are all things we talked about in the last video. That's what this pathway is doing. So the way this works is, right, if I increase my blood pressure, think about what should happen. If I increase my blood pressure, I want to have more vasodilation. I want to keep things in check. If the pressure goes up, I want to give a little bit of vasodilation, kick up the afterload, bring that mean arterial pressure back into a normal range. Okay, because remember, mean arterial pressure is really just equal to cardiac output times total peripheral resistance. And, for example, if my mean arterial pressure goes up, for whatever reason, the baroreceptors are going to notice that change in pressure, and they're going to try to vasodilate and slow down the heart rate. Remember, cardiac output is just stroke volume times heart rate, right? If I lower the heart rate, if I vasodilate, if I decrease the TPR, that will get the mean arterial pressure back to a normal range. Conversely, right, if my mean arterial pressure goes down, what would I want to do? Well, I can increase my heart rate using sympathetic response, and I can also increase my total peripheral resistance by undergoing vasoconstriction, and that will get the mean arterial pressure back into a normal range. So that's what the baroreceptors are trying to do. So if you understand that, you can understand these signals. If I increase my blood pressure, I want to increase my afferent and efferent parasympathetic firing. I want to increase the firing to the nucleus solitarius, and I want to increase the firing over to the SA node and AV node through the vagus nerve. I want to slow things down. I want to get that mean arterial pressure back at a normal range. So I want a higher parasympathetic response because the pressure is higher. I want to vasodilate. I want to decrease heart rate, decrease contractility. And the reverse is true. If you have a lower blood pressure, you want a higher sympathetic response and a lower parasympathetic response. You have to be careful. Are they talking about the sympathetics or are they talking about the parasympathetics? Okay, remember, sympathetics increasing the pressure. Why? Because we're activating alpha-1 receptors. GQ protein pathway at vascular smooth muscle is going to vasoconstrict, increase TPR, increase mean arterial pressure. And on the other side of it, we are also activating beta-1, beta-2 receptors, GS pathway, increasing CAMP, increasing cardiac contractility. Okay, so just kind of putting it all together. Now, if you have a patient that has a very high heart rate, for example, there is another concept here. That's the carotid sinus massage. So the idea here with this is by massaging this area at the carotid sinus, you're making the carotid sinus think essentially that there is a higher pressure because you're putting pressure using your hand on that area. So when you do that, the body reacts thinking that the pressure is higher, even though it might not necessarily be higher. So of course you're going to have an increase in afferent and efferent parasympathetic firing because the body thinks that the pressure is going to be high. It thinks that the mean arterial pressure is high. Okay, does it know that you're massaging the area, right? And so that's why you're going to have more parasympathetic firing for a parasympathetic response. So carotid sinus massage should give you a parasympathetic response, and it's going to cause vasodilation, decrease in heart rate, and decrease in contractility. So what happens is if you have a patient that has a arrhythmia, particularly the big one is going to be supraventricular tachycardia or SVT. And that patient, a lot of times what we will try to do initially before we start to give medications is we'll do a carotid sinus massage first. So if you're, in the wards or, you're seeing a patient and they go into SVT, you do a quick EKG, say, okay, this looks like SVT. And what you'll see the resident or the physician doing is they'll start massaging the carotid sinus to try to get the patient to decrease their heart rate, because in supraventricular tachycardia or SVT, the heart rate's going to be really high, 170s, 180s, and they're trying to get the heart rate down. Now, if that doesn't work, then sometimes we'll go to different kinds of medications like adenosine, for example, which I will talk about at some point. But again, the idea is this is a vagal maneuver. We're trying to stimulate the vagus nerve, right? Because that's the efferent part of this pathway to decrease the heart rate in conditions where we have tachycardia, particularly SVT is the big one. Now, the other thing is some people can actually be very sensitive in this area. So they're thought to have carotid sinus hypersensitivity syndrome. And the way that they ask about this in a board question is they'll say, it's usually an older patient, usually an elderly male, and this patient will develop really severe hypotension and bradycardia after some kind of stimulation. And they're not always going to tell you the patient was massaging their carotid sinus or something like that. Maybe they had a tight shirt collar or something that was putting pressure on that area. Maybe they were shaving, okay? And that might have caused them to feel very dizzy or have a syncopal episode. Now, the key here is a lot of times when you see questions, you'll see, okay, the patient had hypotension, which caused a reflex tachycardia, right? If I have hypotension, my pressure is low, the response of the body is to decrease parasympathetic response, increase heart rate and contractility. So if a patient is hypotensive, I would expect them to have a reflex tachycardia, okay? But in this case, you have severe hypotension and or bradycardia. The reason that you have the bradycardia in the setting of hypotension is because you're just stimulating this receptor. The receptor actually thinks, because this patient's wearing a tight shirt collar and they have high sensitivity to the receptor, the body thinks that the pressure is actually up. So it's not going to have a reflex tachycardia. It's going to have a reflex bradycardia to what it thinks is a high pressure, when really it's just the shirt collar that's pushing on the carotid sinus. This is also what you see with neurogenic shock. You see hypotension in the setting of bradycardia. Always look, when you have a hypotensive patient, if you don't see them tachycardic, there is a problem, right? They should be tachycardic. Otherwise, this might be neurogenic shock or carotid sinus hypersensitivity syndrome. The last thing on here is the carotid and aortic body chemoreceptors. And again, just be careful here. Carotid sinus, carotid body, right? Aortic body. So the body is associated with the chemoreceptor, not the baroreceptor. So it's kind of confusing because B, you think B body, B baroreceptor, don't do that, right? So the B body is for the chemoreceptor, okay? So the carotid and aortic body are associated with chemoreceptors, primarily detecting changes in oxygen, particularly hypoxia, hypercapnia, high CO2 levels, and a low pH. Okay, and generally when these situations arise, the sympathetic response will be, hey, let's increase the respiratory rate. If I increase the respiratory rate, I can blow off this CO2 and even potentially improve my oxygenation. So that's the idea. Where this comes into play, where this gets a little tricky, is let's say that you have a patient that has COPD. Okay, so let's say you have a patient that has chronic COPD. So these patients, chronic COPD patients, will typically have very kind of shallow respirations. They're going to have tons of dead space. They're going to have very, very high residual volumes, okay? And we'll talk more about this in the respiratory section. But what you have to know here is they're going to have very, very high levels of CO2, okay, in a chronic COPD patient. And these patients, they're going to be retaining a lot of the CO2 because, again, they have high tidal volumes. They don't have great elastic recoil to get this air out. And so they're going to, like we said, they're going to be retaining the CO2. Generally, these patients, you say you want their oxygen usually between 88 and 92%. And you'll see this a lot on your rotations and that kind of thing. And you'll see, one of the staff members might come in and tell you, hey, this patient's at 89% oxygen saturation on room air. We need to get them on oxygen right away and get their oxygen up to 97%. Okay, that's not always the right thing to do, because in a COPD patient who has really high CO2 levels, if you give this patient a ton of oxygen, you actually decrease their respiratory drive. Okay, the only thing that's allowing them to breathe or telling them to breathe is the fact that they have low oxygen. That's what's telling them to breathe, okay? Because here's the thing. If you have high CO2, the response is to increase the respiratory rate. But if I have a high CO2 for years and years, eventually it's going to be desensitized to that receptor. So the body's not going to care that the CO2 is high. It's not going to always have the respiratory rate high. We couldn't live with a high respiratory rate all the time. We'd tire out, okay, and we'd have to be intubated. The point is that COPD patients are very reliant on their oxygen sensors in the body, and the oxygen chemoreceptors. And when that oxygen level goes up, the body thinks, oh, we don't have to breathe anymore. We have more than enough oxygen. And so that's where you decrease the respiratory drive in a COPD patient, making their hypercapnia worse, because now you can't blow off all of this excess CO2, and that can be a really big problem leading to respiratory failure. Okay, so that's why the ideal oxygenation in general for COPD patients, chronic COPD patients, is usually actually between 88 and 92%. That's more of a high yield thing for step 2, but this whole concept is very pertinent to step 1. And the other idea is the most effective sites at responding to the chronic hypoxia is generally going to be actually the peripheral chemoreceptors and not the central chemoreceptors, which is another thing that often gets confusing. So also remember that.